how it's not always a good thing that modern medicine has turned many fatal illnesses into chronic ones.
Hey, I'm Dr. Julie. I'm a board certified psychiatrist. Looking at this video, as always, go back and watch the full video for context. But essentially, the creator is speaking about her caretaking for her father who had a type of dementia called frontotemporal dementia, and how in the past he would have died from a number of other like immediate or acute medical events he had, like a stroke and pneumonia. But ultimately, due to interventions of modern medicine, he didn't pass away from those things. He ended up passing away from the complications of the dementia. And, it made me think about a case, really early into my career as being an attending. So, that first year and a half out of a residency, I was working in a VA outpatient clinic. And, VAs, they're like chronically understaffed. So you're always like starting to work with this one position and then maybe assigned to you to cover other things. And so I was supposed to be just doing like regular, clinic outpatient work. But due to the shortages, I got assigned to this. I guess the best way I could describe it is, I guess, like a nursing home, but they also had a component of it that was kind of more like subacute kind of care. But some people did stay there for, like live there kind of for extended periods of time. So I was consulted on this case. So it was a gentleman who had schizophrenia. So, a chronic serious mental illness, but on his medication had been, successfully managing his career his condition for like his lifetime, basically. Like he worked, I don't remember the occupation, but I remember like he worked, he was married, he had a family, he maintained his house, like, lived, with his condition, just like a normal life, quote unquote, normal life. So what happened is he had a stroke, and following the stroke, he just could not tolerate the same mental health medications. And particularly, he had something after that stroke called a prolonged QT syndrome. So QT basically is a measurement of the distance between the Q and the T on the EKG. That's like the best, simplest way to describe it. And it's like measured in milliseconds. And essentially, if that is longer than normal, that measurement is longer than normal, it can lead to a severe arrhythmia or abnormal heart rhythm, and it can be fatal. So it's possible with a lot of different, not just mental health medications. Those are the ones I tend to think about. But other medications can do it too, like some other medications for other cardiac conditions, some medications for GI stuff. There are some medications, if you mix them together, it's more likely to cause prolonged QT, like certain particular medications for like reflux. So anyway, it's a lot of different medications that can do it, particularly in certain combinations. But mental health medications are kind of the ones that are, I guess, more known for prolonging or extending the QT interval. And so essentially, after this person had the stroke, he had that, and he could not take the same medications, the same antipsychotic medication. And so he just became completely disorganized. So he didn't actually have much complications, either cognitively or physically from the stroke afterward, but his mental health, he just became totally disorganized. You couldn't hardly understand his speech. It was just like garbled word salad, what we call. He was doing things like, like urinating or using the bathroom and kind of smearing things around. He was just totally unmanageable, not redirectable. Like there was almost like no communication either way with him. So they asked me to consult on the case because the other doctor in the facility had, tried most what they could do. And whenever they gave him antipsychotic medicines, he would get so much better almost instantly. But then he would have the cardiac finding, the QT interval. And so they're like, well, we don't want the QT interval to go too long because then he might die of this arrhythmia. But, he's basically, we can't even hardly manage him here. So I met with him, kind of confirmed the assessment. Then I met with his wife, who at that point was like his decision maker. And I kind of talked to her about this dilemma, essentially. And she said that what she thinks he would want is his quality of life. So even if that meant that he would die sooner, die earlier, she said he would want to die, quote, in his right mind. That's what she said. So for me, it was a real ethical dilemma because, really at the core of do no harm, it's me thinking like, okay, I know if I give this person, if I prescribe this, it's going to cause a harm. potentially the patient's going to die. And like, just me contending with that, like, I'm directly going to do something that might lead to this person's death. Okay. So I ended up putting in an ethical consult at our hospital just to get some other thoughts about this, because again, just at an individual level myself, I'm like, I don't even know if I feel comfortable like prescribing the medicine knowing that the course that we're likely going to go down. I don't even know if I like personally can do it. So we had this ethics consult, and they end up writing this kind of summary of everything in the chart. And I mean, they don't make any decisions, but essentially, my assessment of how they left it is, this person has a decision maker, and the decision maker, is basically logical, reasonable. That's who the person they appointed to make the decisions for them. So, like, basically, ethically, that's kind of the course to go on. He left a person in charge to make his decisions, and so, like, follow that person's decisions. That's how I felt they left it. So after giving it, quite a bit of thought, and based on the history that they say he cleared up so quickly, I started prescribing him, lower dose of antipsychotic medicines. And he did. I mean, he responded, and we got to a certain dose. It was not miraculous because I know how the medicines work, but just to see how much he improved, in such a, relatively short amount of time, I felt like, okay, this is the way to go. So eventually, he did clear up enough that I was able to have, a conversation with him about the risk and benefits of kind of continuing down this course, of where he was, like, before we actually, gave him the medicines and the behaviors and how he was functioning. And, because he didn't hardly have any, like, full recollection of what his behaviors were when he was off of the medicine. So I ended up, kind of explaining and, kind of saying, hey, if we continue giving you this, it's likely that this will be the outcome. And he said, I want to go home. If I'm going to have a shortened lifespan, I would rather go home thinking clearly, making decisions about my life and, doing what I want to do in whatever time I have left. So he did. And, I would say within like a month of starting that and the monitoring we did, he was able to leave the hospital. And at least in the time frame that I remained in that position, I didn't hear anything about him passing away. I think they probably will let me know, considering all of the kind of particular circumstances. But I guess he went to be, followed by his outpatient team once he got out of the facility. But I'm telling this story to say that it brought home to me really early in my career what it really means to have your quality of life, whatever that means to the individual, and allowing them, if they can, to have some say in what they would want. Often what I would find, because, psychiatrists are consulted on a lot of cases towards the end of a person's life, whether that's for the person specifically who's dealing with the issue or even their family members. And oftentimes what I would find is that it would be the family members who would really be pushing for these life extending treatments, very invasive treatments to prolong, a life. Even if the person may be cognitively not there, they would oftentimes be pushing for this. And again, if that's the person's desire to have those treatments and you're their decision maker, then I can see why, they push so hard. Because if somebody made you in charge of their final wishes and they said they wanted a feeding tube or, something else like that, then of course, you're probably going to take that responsibility very seriously and do everything you can to follow through with those desires. But more often than not, either the person who they're making decisions for didn't really what they would want, or the person has just not come to like the acceptance that their loved one is, nearing the end of their life journey and is suffering. They don't realize the degree of pain and suffering that their loved one may be going through, continuing with all these invasive treatments. And that's where I think that those of us who work in helping professions can do a lot to help family members understand, what their loved one is experiencing, and then also to support them to be like neutral and non-judgmental, whatever decisions they decide to make. Because, sometimes people will be at one point and feel a certain way, and then as they continue to go through the process or see their loved one go through all these invasive treatments and things like that, they'll change their minds. So being non-judgmental, I think, is important either way. But I did want to share that it brought home to me the importance of quality of life like very early in my career.